So we'll go on to session number 18 now. Scalp micropigmentation and other camouflage techniques. Could I call upon Dr. Sandeep Sattu sir to moderate the session, please?
For this session, I invite Dr. Mysore Venkatram to speak on managing difficult hair cases in hair restoration.
As we come to the end of this conference, we come to this difficult topic of difficult cases. Happy Women's Day to so many women here. I think people didn't realize it. None of the women also. What is difficult? The difficulty can be purely from a surgical point of view, and these have been discussed over the last 2 days in many ways. Difficulties can be in medical infrastructure. These also have been discussed to some extent. Then difficulties can be in pure logistics, particularly in Indian situation, like power going off in between your transplant, your water tank going empty, such things, or your nurse not coming up. This lecture will deal with certain other types of difficulties. Now see this case. After his FUE, you can see that there is a patch of alopecia here, which is due to unadjoint effluvium. This is supposed to be due to a tight scalp, tight suturing, and which interferes with the blood supply and is usually temporary. They invariably gain the hairs sooner or later, but at that time it can cause anxiety to him. It can also occur after FUE, particularly if you do over-harvesting. Now I want to show this case because I don't think this topic was discussed at all in this conference. Repeat transplants, second hair transplant. Now this, he already had a first hair transplant. This is the result of the second one. But what happened? Okay. Now, but then, what are the factors that affect the second hair transplant? How much does the fibrosis, altered vasculature of the first transplant affect the result of the second hair transplant? This needs an entire lecture, but this is something which has to be considered, and then they should find a mention in the consent form. Second hair transplant can be a little more unpredictable when compared to a first transplant. The second issue is if it has, first one has failed, whether you do it or somebody else has done it, and the patient is in a hurry, he is already unhappy, he is in a hurry to get the second transplant. When do you do the second transplant? Can you do it at 6 months, 9 months, 12 months, or even longer? I would like to think that one should at least wait for 12 months because delayed results can be seen. But often patients push you to do it earlier. Now see this patient. This area was the area where body hairs were mixed with scalp hairs. And many of the body hairs did not grow by 1 year. Now this raises the question, we know that, or we think that body hairs get synchronized with scalp hair because of the recipient health influence. How long does it take for the recipient influence to show its effect? Body hair cycle is different. So they are shed off earlier. They come back, the second cycle also, telogen is longer. So how many cycles does it undergo before its unadjoint hair gets sufficiently prolonged? I do not know if this has been studied adequately. Maybe we should discuss this in the panel discussion. But I would tell my patients that the body hair can take anywhere from 1 to 1.5 years before those reports are seen. There is one publication, I think by Kavish Chauhan, which dealt with the rate of growth of body hair, scalp, beard and body, and that showed that beard hair grew fastest, followed by scalp hair, followed by body hair. Now imagine this situation, particularly for a plastic surgeon. Patient arrives to the clinic, he has been on email consultation with you, then you discover a patch of alopecia areata, this was discussed, so we will not discuss it again. You find that he has a patch of psoriasis or vitiligo elsewhere. Now in these diseases, difficulty is not about the result. It's also about cobnerization of the skin disease, which can lead to flare up of the disease. Now in such situations, those who are not dermatologists should not decide it themselves. They should consult a dermatologist to decide the activity of the disease. Psoriasis can increase bleeding of the scalp because there is increased blood supply in the psoriatic lesion. So it needs to be treated well before surgery. Vitiligo, the saving grace is scalp is affected last in vitiligo. Scalp hairs remain black almost till the very end, except rare cases. So it is not that much of an issue. Now this was a patient whom I had. Patient with recurrent pustules. Normally you see pustules, they occur in end of first month, second month, maximum third month. They disappear afterwards. This patient, he continued to get them almost till 7 months, and then it affected his outcome also. These pustules are thought to be sterile and is thought to be a foreign body reaction to keratin, which is released from a broken or an altered shaft. Now, what is the role of sebaceous glands? Particularly, they are big in miniaturized hairs. What is the role of pityrosporum? That is something which we have to understand more. Now, in fact, it has always been a mystery to me why we don't see these pustules more often than we actually see. Miniaturized hair shafts actually have larger sebaceous gland. So, even in a completely bald scalp, there are large sebaceous glands. So, they are getting injured. So, why are we not seeing them more often? And then, does isotretinoin have a role in the management of these patients? This is something which I have not done, but I am throwing it up as a question. Now, in this particular case, there was one additional difficulty which we many times face. The patient was from a different country. So, getting a consultation was not that easy. I knew a dermatologist there and I asked him to see him. The dermatologist made light of it, just gave clindamycin lotion, but could not convince him like we would do. Then I asked him to see a local hair transplant surgeon whom also I knew, but unfortunately that chap kept doing PRP to this patient, and what he charged for PRP was almost as much as I had charged for hair transplantation, and that made the patient even angrier, that he spent additional money, neither the pustule subsided nor the results came. Now this is a case from Dr. Madhura from Bangalore. She has asked me to put up this case. She is not here, she left yesterday. She has seen some South Indian patients with a past history of recurrent folliculitis with seborrheic scalp. Patient also had a mild cutis gyrata, but there were no scars of folliculitis. While doing transplantation, she had increased bleeding, which led to difficulties in extraction. It also led to increased transaction rate and a delayed surgery. So she would like to know how it should be prevented and moderated. And I think we have a moderator after this. I would like him to take up this case. But my hypothesis or my thinking would be that these patients need to be treated prior with long-term antibiotics and if necessary with isotretinoin. But the problem is often these patients are by email consultation and they land up on the day of the surgery and then you find he has this. There is only so much you can find out by email, and some of these problems are big because of that. Now this brings another question. What about hair transplantation in a patient who is on isotretinoin? The plastic surgeons might not be familiar with this issue, but generally we dermatologists are somewhat hesitant to do any surgery or even procedures such as laser in a patient who has been receiving isotretinoin. In fact, till recently, the recommendation was that in such cases, on isotretinoin, you must avoid surgeries for 6 months. And recently, we came up with guidelines. In fact, I spearheaded that effort to do a multicentric trial wherein we showed that most superficial, minimally invasive procedures are safe. But we did not include invasive procedures or surgery. And hair transplantation is far more invasive than the other dermatological procedures that we do. So the answer is not clearly known. So since isotretinoin can affect both epithelialization as well as collagenization, it is perhaps safe to avoid isotretinoin surgery in such patients. But it is also true that the isotretinoin receiving population is much younger, 20, 22 for their acne, not 25, 30 as we do. I have requested for a few additional minutes, and I hope I have them. Now, these are some of the difficulties that we face on the day of the surgery or just before. A minor borderline ECG abnormality, borderline HbA1c, borderline hypertension. Now, patient has come from somewhere, you find this, then it is a difficult thing. Local patient can always be sent back. But this is a practical difficulty you have. Recently, I think Mayank put up a case on the WhatsApp group that on the day he had an issue like this, and then he had to get an emergency physician opinion for that patient. Now, if a patient, we had this patient who came from Singapore. For some reason, he had been on high dose propranolol for his hypertension. We had asked the history, he said, I am well controlled. Blood pressure I have, but it is well controlled. When he came, we found that he is on propranolol. Now, giving adrenaline to such a patient receiving propranolol is an issue. So, physician said we have to change the drug. But if you change the drug, what will happen to the blood pressure? So, we actually postponed the surgery till he was shifted to another country. He was actually from Hyderabad, so he went to Hyderabad, came back after a few days. Patients on antiplatelet drugs. This is a frequent difficulty that we get. Patients request for this. Now, one basic principle, stopping life-saving drugs to perform a cosmetic procedure is unacceptable and indefensible. Now, if you do HT on such patient, there is increased risk of intraoperative bleeding, delayed surgery, post-operative hematoma, possible dislodgement of grafts, and poor outcome. All these are possible. So, they need to be explained. Likewise, these patients often have a primary heart condition for which adrenaline may be contraindicated. So, not giving adrenaline further enhances bleeding during surgery, and that may also decreases the duration of anesthesia. That may make you give more xylocaine with possible cardiotoxicity of xylocaine. You can't give bupivacaine for such patients because of possible cardiotoxicity. So, what do you do in such cases? I have done 3 cases, but always in presence of an anesthetic, but small cases without much difficulty. And this, in fact, I had it about 4 years back. I have made extensive consultations with several hair transplant surgeons. There is one publication in ISHRS forum, which I recommend that all of you should read, wherein I think it was a Japanese author. He discussed 8 different scenarios wherein he had to tackle this, and in each scenario he has given a recommendation. Anybody who is doing hair transplantation should refer to that article. Now, this is another situation. Patient who is 74 years, who is otherwise healthy. Now, anything can happen in a 74-year-old. I mean, I hope there is nobody who is 74 here. But anything can happen. So, what happens if it happens during the surgery? Not due to transplantation, but anybody. So, these are situations that we face, and there is no single answer for that. Now, I had a patient who, at the end of the surgery, said he won't take analgesic. Why? Because he had asthma once after taking diclofenac. Now, he had come from Dubai. You put him up into the hospital, in the hotel, if he has severe pain, what does he do? Or if he ends up taking an analgesic for that, and he gets asthma in the middle of the night, what do you do? So, what did we do in such a case? We admitted in the hospital, and we paid for that. He was not willing to pay. He said, all right, we will pay you. So, that solved that problem. Then there was another patient who had a paper that while doing, I think, ganglion excision or something like that, he collapsed with syncope, and then he was allergic to, the orthopedician had written, allergic to lignocaine. Now, the history suggested that it probably was not an anaphylactic reaction. It was a syncope. But on the other hand, one doctor has written that he is allergic to lignocaine. You can't overlook it. So, we had a detailed discussion with the patient. And the patient himself was very keen that he wanted to know what is the status. Is he allergic or not? So, what did we do? We admitted him in a tertiary care hospital where the test dose was given in the presence of an anesthetist. There was no reaction. We kept him one day in that hospital to observe any late phase of allergic reaction. This was about 1 week after the delayed anaphylaxis in Bombay. So, we did not send him home. And then the patient was operated later. That day also we kept him in the hospital. We didn't send him home. So, all this was done to take care of that particular need. Now, just compare it with what I had done myself in 2008. There again, I had one patient. In fact, the patient was from Korea, and the patient wrote, I am allergic to xylocaine, will you operate me? Then I had taken out detailed history and found out from the history that he probably did not have true anaphylaxis, they were just syncopal attacks. He came, and then we did do testing in our center itself in presence of an anesthetist. But this time in 2020, I did the testing in a hospital. That is the difference between 2008 and 2020 as far as patients and doctors are concerned. Then, this question was asked by Ramachandran yesterday, and I myself have grappled with this without a good answer. Should you do hair transplantation in a patient who is alone and from a different city or a country? Is it practical to have an attendant in every case? If he is alone and he develops a problem, related or unrelated to hair transplantation, he needs an admission. How do you handle it? Who will take care of him? How long will somebody take care of him? Who will pay for the expenses? So, what are the answers for this? If you see our medical legal book, there is a chapter by Dr. Srirang Pandit in that, and he grapples with that problem in that book. He quotes 2 cases wherein he refused liposuction for 1 or 2 young people who came for it, saying that you need to have an attendant. In one case, the lady came back with an attendant who signed, and then half an hour later disappeared. He found out that he was not a relative at all. It was just some casual person whom he had brought just to show to the doctor and get surgery. So these are all the practical difficulties that one can get. Now the summary of all this is hair transplantation is a surgery. It is peculiar in the sense that many patients come from elsewhere. So our responsibility is greater, not just in giving aesthetic result, but also in giving medical care, and more importantly in a moral sense, caring for the well-being of the patient as long as he is in that station. And the difficulty there is in maintaining balance between not wanting to lose a case and in saying no. And it's also in being open, discussing and seeking opinions in overcoming our egos. Thank you very much.
I now invite Dr. Rachita Durat to tell us more about scalp micropigmentation.
Very good morning. We'll talk about micropigmentation in FPHL. Before that, I would like to invite you for this Trichology Update Conference, which is the 5th annual conference. And this is our team. We are inviting 5 international experts in trichology, Australia, USA, Spain. And this will be the wonderful event to learn only about the trichology. And this is open to only dermatologists and plastic surgeons. So we'll talk about micropigmentation. When you look at this video, it looks very simple. But however, it is not simple. It consists of an interlinked relationship between art, science, and maths. So what is SMP? SMP is deposition of pigment which is lesser than 1 mm in diameter, creating an illusion, which illusion means it's a contrast between the color of hair and color of the skin is reduced. So to show that how is this illusion, this is a patient, and when we do SMP, you don't see the skin. The contrast is reduced. That is an illusion. So SMP is nothing but creating an illusion. Why SMP for females or female pattern hair loss? So for that, I would like to share some scenario. This patient had undergone hair transplantation, and look at this. After hair transplantation, you can see her baldness. That is obvious. And this is the best the person can do the hair transplantation. Second, the scenario is where you have the thinning on the mid-scalp as well as on the occipital area. What you do? And third scenario, where the patient has very diffuse overall thinning everywhere, which means you do not have very good donor area. So SMP plays a role in such conditions where you don't have good donor area. Most of the female patients are reluctant to go for hair transplantation. If you look at Dr. Manoj Khanna is not here, but then he has done 7,000 surgery. Out of 7,000 surgery, hair transplantation was done in 1,500, correct? Which means it comes to 21% of hair transplantation in women. Women are very reluctant to go for surgery. And those who are willing to go for the surgery, they do not have donor area. If they have the donor area, they do not have budget also. So this is my journey in SMP. I learned micropigmentation, making a tattoo also. This is, I have done tattoo on my residence. And then I venture into this field. So there are certain optimum variables required for good SMP, like angle of needle against the scalp, depth of it, time of needle left in the scalp, speed of the rotor, resistance of the scalp, and color, pigment, viscosity, number of needles, pattern of dot replacement, and experience of operator. And since it is only just 10 minutes, I can give only overview of SMP. I can't deal in detail about SMP, but however, you can refer this published article. Just take that angle of needle, whether it should be vertical or if it is at angle. So what we did, we purposely did at angle and look at these dots. They are not linear. They are they are not circular. In fact, they are linear. So these dots do not give the natural look. Vis-a-vis, when you have the vertical position of needle, which is perpendicular to the scalp skin, you get circular dots. Now, which needles? There are various types of the needles. For scalp micropigmentation, you require a round shaping, RS, while body area, for vitiligo, you require either round shaping or round magna, preferably round magna. So I'll show you the difference between what is meaning of RS and RM. Now, this is RS, round shaping. There are 5 needles. They are in round. That's why round shaping. And this is a dermoscopic image of that. These are real images. While this is RM, that is round magna, these are 5. They are overlapping like this. This is also a dermoscopic image. So what we require this type of the needle, which you see here. There are 3 needles together. So this is 3 RS instead of 1 RS. 1 RS generally been used for creating frontal hairline. Now, second study we had done in that to depth of needle into the skin. And we purposely penetrated tattoo pigment at various depth, deep and superficially. And then we did biopsy also of that with the punch remote biopsy. And this is also trichoscopic image. You can have, if you have the trichoscope, you can understand. If you see such a fine dots, then the pigment is very superficial. So this is one of the role of a trichoscope to find out the dots are formed very well or not. Now, depth of needle, if it is very superficial, then you can see only pigment in the epidermis. And this will be washed out after 1 month, within 1 month. While if it is a very deep, it is going up to here, and what happens? It is called as diffusion of pigment over time. And that looks very unnatural. So best pigment deposition is in the upper dermis, what you can see. And then you can see the many fenestrations here. We also did what depth? Though it is upper dermis, whether it is 0.4, 0.5, 0.6. So we had done the various studies using depth needle length at 0.6 to 0.9 mm. And we found that at 0.8 and 0.9 mm, you can deposit the dots, which will be lesser than 1 mm in diameter. I have only 2 minutes. Okay. So these are the next study we had done for how much is the contact time if the dots are more. And then you can see this diffusion is more when the larger dots are there. Why vis-a-vis you have the smaller dots, the diffusion is less. I'll skip that. Then you need to understand the what pattern of placement. It should not be like this. It does not give a natural look, but rather it should be in this fashion where you have the natural, regularly irregular brick wall pattern. So you deposit in that fashion. How to create transition zone, I'm going to skip this, you know that. But then what instrument you require? This is your normal parlor tattoo machine. This is sophisticated one which has calibration here. So you can choose the depth of needle length and you can do your precise. Contraindications is normal contraindication, bleeding, that is a complete baldness. Complications are very minimum, pain and erythema. Allergic contact dermatitis to black color is very, very rare. Secondary infection and granuloma also is very rare to black tattoo. Let me share my results of SMP. Female patient doesn't want hair transplantation. See-through effect, she didn't like this see-through effect. This was post SMP. This girl, only for this area, she doesn't want any surgical procedure, and this is after hair transplantation. This is a female, again, had got a good response after medical line therapy, but she didn't like the frontal one, so we have created frontal margin here. This is created one with one single needle. And this is another patient. So in summary, SMP looks a very simple procedure, but it is a sophisticated procedure. There is a learning curve for that. And you need to understand various variables involved to give you best optimal result in SMP. Thank you very much.
Thank you, Dr. Rachita. I'll be speaking to you about holistic approach in pattern hair loss. Basically, I had mentioned this slide in my previous presentation about the types of hair loss that you see. This is the way I have an algorithm to understand how do I approach the patient. These are various factors based on history, examination, distribution, and the hair procedures which give me an idea of what I'm dealing with. Now, we know that when I'm dealing with a problem that has genetic involvement, hormones to be involved, the environment, lifestyle, and an inflammatory component, it is not possible to have one therapy that will take care of all these options. Moreover, whatever therapy you use, in most cases does not address these main causative elements. I have always felt that the way I look at a patient of pattern hair loss is there is a static component, which means that is the visible deficit that has already been created, that is there, that needs to be addressed. But more importantly, there is a potential component, the dynamic component, which is the potential to get worse with time. Now, this is the component that we don't address surgically. And unless you combine and address both these components, I don't think you will have a successful long-term resolution of the problem. So this is a gentleman that you see. He has frontotemporal recessions, but there is an evolving vertex area that you see. This is a patient's picture taken in January of, I think, 2019, and this is by December. So you see there has been a significant recession. Suppose we had gone ahead and addressed only the frontotemporal component with a transplant in January. By December that year or January next year, he would have receded further. So unless and until you address the dynamic component, you will not have a successful approach. So when you look at doing a transplant for these patients, the problem that you have is that the recipient area is like an ever-expanding canvas, and the donor area is like a shrinking paint supply. Unless you are able to contain the expanding canvas, you cannot control this. Of course, we have expanded our paint supply by including non-scalp areas, but it is not in every patient that you have a very good quality of non-scalp donor available. So the way I approach the problem, at the end of the day, I need to know what I will do for a cosmetic problem. It is a cosmetic problem, it is not a medical disease. So the cosmetic issue can be addressed either non-surgically, surgically, or using cosmetic help. Now, how do I decide in what case what should be done? If there is a diffuse variant of hair loss, I know that the dynamic component is much stronger here and medical management of this patient will be more appropriate as compared to a person who has a more prominent the static component where the frontal framing is lost and youthful proportions have been lost. So getting these proportions and landmarks in place would be the way to approach these patients. Now, I have always used medications before and after surgery, after due counseling. The logic that I apply, and this has been published almost 15 years ago. Starting these two agents 8 to 12 weeks before a transplant helps to increase the anagen-telogen ratio globally. That means it impacts the donor as well as the recipient area. So in the donor area, the increased anagen yield leads to more visible hair. So you are able to get the extractions or the strip harvest more effectively. In the recipient area or the non-transplanted area, it definitely reduces the post-transplant effluvium. These two considerations are always put forward to patients whenever they think of going ahead with this problem. Now, what I also see is that the transplanted region as well as the fringe area surrounding it always has presence of miniaturized hair because you don't have a bald area and then normal hair. There is a watershed area which has this miniaturized hair which respond very well to medications. So concomitant medical treatment improves these results and adds to the result of the transplant. This helps to optimize the use of donor reserves over the patient's lifetime and future needs. Now this is a patient, if you see I have attempted to treat primarily the frontal area and some part of the mid scalp. But if you see the vertex area in this second picture, there is a definite improvement in the vertex area. So just by using about 20 to 2300 grafts, I have given a patient a fairly reasonable coverage, scalp coverage that he can carry on for at least the next few years. This is another patient where we have combined the use of medications. Again, this patient, we have not used huge numbers. When I'm using these medications concomitantly, my number of grafts that I put in is not really very high. Means the average session is around 20 to 100 grafts, which is, I think, a fair kind of impact on the donor area. It really does not deplete it so soon. Here you can see the improvement. We have done the frontal and mid scalp and the vertex has also improved here. Similar case again, I have just dealt with the frontal and mid scalp and we have a phenomenal change in the same. This is what we did only for the hairline. Now here you can see there is diffuse thinning behind. Again there is a big change after using topical minoxidil and finasteride. Many a times we combine the scalp micropigmentation like Dr. Dhurat said to add to the outcome. Now, this is a patient who had a surgery done in UK and wanted more coverage. And we added a session of scalp micropigmentation to help him get better coverage. This is another female patient with the same kind of thing. Another post-operative patient who wanted better coverage. Now, this is a patient pre-operatively whom I have operated. One session of hair transplant, patient felt that the see-through effect was a little more, so he wanted more coverage, but didn't want another transplant. So we added the SMP, and that is what the change that you could see in the coverage. Again, when I say holistic, I mean use whatever resources you have at your disposal to get the patient what he wants. So combining scalp and non-scalp areas, including strip harvest and extractions, you can holistically use all these areas without really depleting the donor reserves and get the outcome that you want. Even in revision transplants, like yesterday there was a paper that was showing about extraction of these. These are placed in a very unaesthetic position. The hairline is all wrong. So we extracted all those grafts and then revised it. But then we don't have the donor area, because once the patient has undergone one FUE by another doctor, the donor area is practically depleted and we don't have more reserves to put in more hair. So we have used SMP to add to that. Hair systems is another thing that we have always advocated. When I see a patient, I give him an option of using hair system as one of the choices for all patients that I see. Shaving, keeping his head shaved, using a hair system, medical treatment and surgical treatment are all the options that we give our patients. Now this is a patient who had a very high expectation for another transplant. So these patients, we counsel them to use a hairpiece and they're quite happy using a hairpiece. The point is that medico-legally also, unless and until you give them all the possible options to achieve their objectives, you are being short. This is the shortcoming of your consultation. And you can be held legally responsible for not telling the patients about all the options available, and there should be no conflict of interest when you give them their options. This was a patient who came to me for a transplant. He was using a hairpiece. The thing was that he had a fair bit of hairline, but hair loss behind it. And this is the picture when he actually uses the hairpiece. I said, the kind of coverage that the hairpiece gives you, a transplant will never be able to give. So the best thing is to continue with the hairpiece, and he was quite happy with that advice given to him. Sometimes you get a patient who's already been using a hairpiece but does not have a hairline which can conceal the obviousness of a hairpiece. So in these cases, we add a small session of transplant to cover the junction where the hairpiece meets the scalp. So this is what we can do. Now he can actually comb his hair and conceal the hairpiece. This is another patient where we have done the transplant in the front, but patch on the back side. We have used hair fibers along with our medical treatments as well as surgical treatments. So as a take-home message, I would say pattern hair loss is one condition where scalp coverage would always decrease with age. There is statistically said that after the third decade, with every decade, 5% loss in volume of the total volume of hair, cross-sectional volume goes down. And you cannot fight this with anything. It is programmed to happen that way. It's a part of aging. You cannot reverse that. So factor that in when you counsel patients for hair transplant. And if you want to prolong the results or increase the interval between two transplants, combining medications with a transplant would be the best way to go forward. I feel that I have been saying this many times. It is not that you can look at only one aspect of the problem. Lifestyle plays a big role in the way your body responds to the environmental stress. And more data is coming up, not only with relation to hair, but with your entire body, how much impact the lifestyle has on your various systems. Thank you. I will call upon Dr. Viral. Okay. He is going to be giving a sponsored talk, which is sponsored by Zydus Pharma, on growth factor hair systems.
Good afternoon, everybody. I'm going to be talking about growth factors in hair care. Thank you, organizers. Now, of course, conventional methods of therapy are used in hair. We know about hair transplant. Of course, that's a sure method. There are many minimally invasive like mesotherapy, laser therapy, PRP. Medical management, still minoxidil and finasteride are the gold standards. But the responses are not always monitored. The responses are not always known. And that is why the search for newer modalities. Now the way forward, growth factors plus, what are these? The new option are growth factors plus the complexes. What are the growth factors? They are nothing but natural proteins. Fibroblasts and keratinocytes, they produce these growth factors. The action of the growth factors, they bind to specific receptors on the plasma membrane to trigger cellular growth, proliferation and differentiation. So basically on the cell membrane, there are receptor proteins. The growth factors bind to them. Through the relay proteins, the signal is, there's transduction of to the pathway. It goes into the cell control systems. From there, it controls mitosis, DNA synthesis, and all other functions of the cell. So it helps in cellular growth, proliferation, and differentiation. Now these growth factors bind to specific receptors on the cell surface to target cells. They regulate the biological activities responsible for repairing cellular and genetic damage. They promote the formation of collagen and elastin fibers. They are also used in skin. Various types of growth factors, we know that they work platelet-derived growth factors, mainly chemotactic for macrophages, fibroblasts, and for mitogen, transforming growth factors beta, then then fibroblast growth factors, endothelial growth factors, and IGF, IL. Where do we source them from? They can be plant-derived, they can be recombinant DNA technology derived, and of course non-recombinant DNA technology derived. Now plant-derived, I don't have any experience of use, and wherever I've spoken to, I don't think there's enough data or proof that plant-derived growth factors do work. There are practically no papers available on this. So we mainly try to use DNA technology derived. The growth factors that I'm using, the source is basically a synthesized human gene joined to bacteria is used to manufacture growth factors on a commercial. The recombinant DNA technology based growth factors are sourced from the human cells. They are very safe because they are 100% homologous to human proteins. You need a product which can be, before being effective, you need to know it should not be toxic, it should not be immunogenic, and it should not cause any harm. And growth factors derived from this source, they are definitely 100% safe. They have no allergic reactions on topical applications. The manufacturing has to be, it has all the debris, unnecessary proteins, and all should be removed in order not to have any kind of reactions. So that is very important. Now, patient compliance, it's basically applied by microneedling. Or sometimes can be injected, though it's not recommended, but we've tried to inject it sometimes if we give local anesthesia. It's a very viscous product, so if you're trying to inject it without any anesthesia or any block, it's very, very painful. So if we are doing a PRP or if we are combining with a hair transplant, then it is possible to inject. Otherwise, if you're applying, just used by microneedling. Less waiting time in clinic. It takes 10 to 15 minutes to do this, and of course, it has no, there's no drawing of blood. So in that way, better patient compliance. Now, what do these growth factors do? They restore normal health and growth factor hair cycle. It's also mixed with apigenin, which stimulates hair growth, acts as antioxidant and anti-inflammatory. Butylene glycol basically for anti-aging, antioxidant, and of course peptides, which help in nourishment. How do we use it? So typically the protocol that we are using is, if you're using a monotherapy, we do it every weekly, 6 sessions, or sometimes every fortnightly, 6 sessions. If we deliver on the same day after the PRP, what we do is we do PRP. In this case, since we always give a block, ring block for PRP, so we tend to inject it, or it can be rolled in, or it can be used intermittent. So if you're doing PRP, we do typically at 2 months interval, and in between we do 2 sessions of growth factors at approximately 3 weeks gap each. So these are the ways to do it. Many times we combine it with other products like vitamins, minerals which are available, mesotherapy, sometimes minoxidil, even finasteride, dutasteride can be done locally. So this can be done to enhance the results. Now what we're doing when we are storing the grafts, we are spraying the growth factors in the medium when we're using it to store the grafts to hope that there will be enhanced results. Now what are the results that can be expected? This was a study done. The object was to see whether growth factor complex, including fibroblast growth factors on AGA, and it showed significant change in hair density and hair diameter. Hair density improved by 21% and hair diameter by around 5%. So definitely it did show the effect for improving hair growth and thickening. Another study which was done in 76 subjects, which clearly showed in male and female patients that in female patients around 19% did not have any change, but the rest, 81% did report were happy or slightly improved. In males, of course, the number was a little less at 75%, but still, considering all the conventional treatments, this is a significant number. Some of the results. Some are with monotherapy and some are with PRP. Thank you so much. Thank you.
We'll start the panel discussion. This was a sponsored talk. This will not be a part of the panel discussion. So Dr. Rachita Durat and Dr. Mysore Venkat can come on stage, and they can be joined by Dr. Rajput and Dr. Garg. We will need to ask some questions. Yeah, an important announcement which I forgot to make, just 1 second, 1 second, is that the checkout time is 12 to 12:30. So I request you to just check it out and then come back for the session if you haven't checked out already. It was my oversight that I didn't make an announcement in the morning. Okay, I'll take one question from the floor before I start. Boliye.
Good morning. I'm Dr. Soumya, plastic surgeon, Baroda. I have a question for Dr. Rachita. Ma'am, when we are starting off doing SMP, what dye to buy, which company, what is the cost?
We are going to be asking those questions.
So
that is a part of the panel questions.
Okay, fine.
So I will be going to it in a systematic manner. So we will not miss out on those points. If I miss out, then you are welcome to ask those questions. Okay, Dr. Venkat, you mentioned that there was a slide about when to do the second surgery. What would be the rationale to decide the interval between two surgeries, and how would you choose the rationale? I would like to know the recipient area factors and the donor area factors which will help you decide the interval between two sessions.
See, the donor area factors depends upon whether it is FUT or FUE. FUT would take longer time to heal, and any scar, since it undergoes remodelation for nearly 3 months, 4 months, or even sometimes 6 months, so it should be done only after that. But the FUE, you are actually doing it in a different area. You are not doing it in the same area. So I suppose FUE can be repeated pretty quickly as soon as the first one would heal. Even 2 weeks or a month should be enough there. But recipient area, now that is a little more tricky question. Now we normally say that the results take 9 to 10 months. What does that mean? Does it mean that all the hairs we have put, they have grown, or does it mean that they have not only grown, but they have achieved the required length to achieve the cosmetic result? Now, if it is the second one, and if you say that in some cases there are delayed results, and that is documented up to 10 months or even 12 months, so I would like to delay it at least till 12 months are over to see if every possibility of every hair being able to grow is exhausted. So I would like to do it after at least a month or even a little longer. But in some cases, the patient is in a hurry, he is anxious, he is getting married, he is going abroad, whatever. So in such cases, if he presses you, if you do, can you do it at 6 months or 7 months? And if that is the case, if there are some roots which are still capable of growing, what will happen to them if you transplant
Precisely the point. See, the issue is that when I look at these scenarios, it's very clear that if I'm doing a second session from a donor perspective, whether it is strip or an extraction, the healing is more or less the same. It is the scar that is there of the strip does not interfere with your areas from where you are going to harvest. So that technically, in fact, that skin is more normal than it would be with an FUE. The scar is at a different area, and we are doing FUE at a totally another area.
I meant FUT after FUT.
No. I am talking about a different scenario. So when I
FUE after FUT, we can do it next day also. How does it
No, that is possible, but I am saying if there is an interval. The other thing is that even to do an FUE after an FUE, the problem is that when you have looked at the FUE sites, that definitely takes anywhere between 3 to 6 months for optimized healing. Because if you see the patient's complaints, they have some kind of niggling complaints that come even at 3 months post the surgery. So if there are complaints, means there are issues that have not completely been taken care of by nature. So you have to wait that much time. When it comes to the recipient area, I feel that if you are operating in the same area, 12 to 15 months should be the guideline, whatever be the patient's request. And if you are doing in another area, then 3 months post you can do in an area that has not been transplanted, you can definitely do after 3 to 6 months. But provided you have the same factor that applies to the donor area.
Yeah, absolutely right. If you are selecting like I do it, I have done the frontal area, then I want to do the crown area or mid scalp area, then I can do it at a much shorter interval, and also the donor area is differ also. So in that case, that will be taken as an isolated case or a separate case. You are implanting in a different area, you are also harvesting from a different area. So this you can do it, rightly said Dr. Sattur, 2 month interval, 3 month interval, it can be done when you are taking from and when you are giving, means the recipient area different. Then otherwise it is better if same area, recipient area is there, then it is better to wait for 12 months at least.
Okay. The next question, you want to say something?
Mainly the question we are raising is in concern with body hair transplant. You do body hair transplant, that's what Venkat sir was showing. You do body hair transplant, then how long will you wait?
No, that was a different question altogether. This was just primarily the interval between two surgeries. And I'm talking only about scalp surgeries, that is all.
I am sharing a experience where we have mixed body hair with scalp hair, and then the patient is not happy with the density. And just within 6 months or 7 months, the patient started pestering that you do another sitting, that hair is not growing. So I was reluctant to do the second sitting, and I wanted to make the patient wait naturally. But even after explaining that body hair might grow at 8 to 10 months, you shouldn't be in a hurry to say that this is not growing. So we delayed the procedure by doing repeated trichoscopy. Whenever the patient came, we said, okay, let's do trichoscopy. We see, you can see those hair are there on trichoscopy. Then you could gradually see that those hair are slightly growing. And we delayed, and by the end of around 10 to 12 months, there was no need for doing the second sitting, that hair was growing.
Okay.
So convincing the patient is the
crucial.
matter. Then you could do serial trichoscopies to show the patient how is the progress.
Okay. This question is for all four of you. As I understand, the anagen-telogen ratio on the scalp is very different from that on the, let's say, chest. I'm not talking of the beard, let's say the chest. So given that if the anagen-telogen ratio on the scalp is 90:10 and on the chest is like almost 40:60 or 30:70, various books, there's a very ambiguous number that comes up. But the fact is that there are less follicles in anagen and more in telogen. So that technically means that the number of hair that are seen on the chest, majority of them are in telogen. So how do you take this inference and plan your surgery vis-a-vis the outcomes to be projected to the patient?
Yeah, this is a very good question, and this needs to be explained to the patient. We understand what is anagen and what is telogen, but patient doesn't understand, so the best word I use is sleeping, but they are alive. So I explain them, see, if I take 100 grafts from your chest, one thing you have to exclude telogen from the donor area. The best way is, simple way is the shaving, number one. Number two is you can see the epidermal blush. If you use good magnification, then you see the epidermal blush. If that is present, means that is the anagen hair. So these are the two things to select the anagen hair from the donor area. Now for the recipient area, I tell them, I'm going to harvest the 100 hair from the chest, and here you will show only 30%. They immediately say, so 70% will be the loss. No, I don't say, my meaning is not this. I will put 100 hair, 100 hair will be alive, but given a time, 30% will be in a standing stage, 70% will be in sleeping stage. How come? Then I explain what is sleeping, what is telogen. Then I tell him, in next cycle, this 30% which were standing will go on sleeping and another 30% will come. So given a time, 100 hair will show only 30 hair. So don't think that by putting 100 hair on the top of your head, you will see every time 100 hair. Every time you will see only 30 hair. So the sleeping word is a better word for explanation of the patient regarding the telogen status of hair, and this should be explained, well explained to the patient.
Okay. Anybody else having a differing opinion?
I would like to add, when you are taking hair from the chest, where maximum hair are in telogen phase, that means you are taking all telogen follicles.
That's he clarified that. He will be taking only the anagen ones from that.
So the explanation is that when the telogen phase you are putting into the recipient area, that telogen will go into anagen, and anagen will go into the various 6 stages of anagen phase, and then it will come out. So it will definitely be delayed than what hair you are taking from the occipital area.
Okay.
See, this is what I mentioned. Now that cycle will be different from the scalp hair cycle for some length of time. Now the assumption is based on recipient influence, at some stage this cycle at least partially will get synchronized with the scalp cycle. When that happens, I do not know if there is an answer to that question. The assumption again is, by about 3, 4 or 5 cycles of body hair cycle, it will get synchronized with the scalp hair. Now, whether it is 4, whether it is 5, whether it is 6, so the best is to explain to the patient that the body hairs will show some result much, much later. Maybe 1.5 years or even longer. I think that is a fair way of example.
We can use the word unpredictable in terms of the outcome of the result being seen in a time-wise manner. We can predict the outcome in a scalp hair more
Faster.
with a more sure way because that is the reason why we can. This has to be factored in the consent taking part, that the results do not come on the same time as the scalp hair. You're saying something else?
We have had not many, but about a couple of patients in whom we started using minoxidil foam on the chest before taking them for body hair, harvesting body hair. And these hair have behaved better. And if you continue that minoxidil application starting 10 days after the surgery, apparently it seems that the time delay of that body hair coming back and growing into anagen has been less in these patients, but it's like only 2 patients.
Okay.
Means you need to follow that up more closely. But one thing is for sure that 2 to 3 months of minoxidil foam application on the chest area resulted in majority of that chest hair coming in anagen.
Okay, I'll go on to the next question. It is regarding the internet consultation that Dr. Venkat mentioned. I will ask the panelists as well as the delegates, how many of you do internet consultations, whether it is through mail or through Skype? How many of you will charge for them? Okay. A recent ruling from the Medical Council of Maharashtra.
I want to mention here, my consultation is only regarding a broad advice. I do not prescribe anything.
No, I understand.
So I do not charge.
No, we give an opinion. That opinion itself is debatable. Not having seen the patient in person, even if it is Skype or email, it is not permitted by law. This is something that you have to make. So there has to be a disclaimer in your answer. In your signature, include a disclaimer that whatever opinion you are giving is purely on the basis of pictures and should not be construed as final and will change when you see the person the patient in person. And technically, this should not be chargeable.
Yeah, yes, you are absolutely right. There should be one disclaimer for that, and merely giving just on the pics, rather it is better to do the Skype, and it's better not to charge, and if you are sending him the treatment, you should mention it.
No, I think even advising treatment is fallacious. If you are not going to be giving an opinion, if you are giving it, it is not final, you cannot be prescribing anything for him. Technically, prescription is where the bigger problem is. So, no prescriptions, you can just give an opinion on the problem. On the problem. Never that these many grafts are required, because that is the commonest query. How many grafts will I need? I say I will tell you when you see you. So, that is a safer way to deal with this from a medico-legal perspective.
I want to differ slightly in this. See, general advice with a disclaimer, even if you are mentioning the number of grafts, I think is fair enough. If I see acne scarring, I can tell the patient will need laser. To that extent, it is possible.
That kind of general
The
is
second
okay.
point I want to tell you, the Medical Council of India Ethics is lagging behind the practical situation in this aspect.
Ethical, I am not saying ethical.
No.
This is legal. We are talking of legality here, not ethics.
That legality is based on what is written in the medical code. Because there it says that you should examine the patient. The Medical Council doesn't mention the word internet, website, email,
So
anywhere.
this is a ruling that came out.
Listen to me fully. Now, on the other hand, digital medicine is being encouraged by the government at all levels, including National Medical Council. Their document, if you see, mentions this extensively. So, and several companies actually have started giving second opinions, radiology opinions are being given. And then recently there was one advertisement in Bangalore that you can access a doctor in 60 seconds and the doctor will tell you what you have. A complaint was lodged with the Karnataka Medical Council. Karnataka Medical Council wrote to them and they gave a lengthy reply including a legal opinion as to why what they are doing is not against medical ethics. But then medical council gave a statement that this is not allowed. Prescription is not allowed. But by a broad advice saying you need transplantation, so many grafts are needed, with a disclaimer. I think that
I
is...
agree with that. But when you talked about digitizing medical healthcare system, that needs an infrastructure at the patient end. So you are either showing an X-ray. An X-ray can be reported from miles across. That is not an issue. In ECG can be reported with clinical correlation. You have, see, the healthcare system that is evolving digitally will have some kind of an infrastructure. The patient's system can be monitored remotely. That is a different thing. I'm talking purely from a hair transplant perspective. Okay, next question. You mentioned about isotretinoin. Our understanding as plastic surgeons is that isotretinoin, if it is used systemically, there is an increased propensity for hypertrophy of the scars if a surgical procedure is done. Now, I always consult dermatologists on these issues because most of the patients are on isotretinoin put by the dermatologists. Now, there is differing opinions from different dermatologists. Some people say that this is not very clearly documented, so you can go ahead and do the surgery. Some people say wait for 6 months. Some people say that no, once he has taken Accutane, then that propensity may be there for life. Now, what is the actual truth in this?
See, this, what you are saying, different opinions would have been valid 2 years prior to 2020. Since 2020, there are 3 guidelines, one by us in India, one in America, 2 in America actually, who have said very clearly that that tendency for keloid is exaggerated, and that opinion was based on isolated case reports published in late 1980s and late 1970s and early 1980s. So there are enough studies afterwards to say that that is an exaggerated risk. So it can be done. But all these guidelines which were published were with respect to dermatosurgical procedures such as laser, botulinum toxin, microdermabrasion, chemical peel, microdermabrasion, etc. It did not include surgery. There is one guideline by British Association of Dermatologists with respect to dental procedures, which says you can safely do that. But there is nothing available. Can you do a rhinoplasty in isotretinoin patient? I would say no. Now, hair transplantation is a question mark. That's why, to be on the safer side, you wait for 6 months.
6 months is the cutoff period, you would say, minimum.
Yeah.
Okay. So that is what we would like to convey to everybody, that 6 months is the time that you would need to wait for a patient to discontinue oral isotretinoin before taking him up for surgery. You have a patient for surgery, 28-year-old male, whom you are going to just take up for surgery, markings and everything is done, you tie the BP cuff, find that the BP is 150/100. What would you do? Would you proceed with the surgery or not? Patient is not a known hypertensive. And what would be the cutoff blood pressure, systolic and diastolic, before you decide that you will postpone the surgery? Do you have any guidelines on this?
The guideline of per se, what we have read, only the anxiety only increases the systolic, not the diastolic.
No, that is different. It can, stress can increase
but
both.
stress can increase. That's what I'm highlighting, that stress can increase the systolic and diastolic. We often get the patient, and we always take patient's BP when the patient is fixed for the surgery, and sometimes many of the patients comes a day before the surgery, and we take the blood pressure on that day also. Then he comes on the day.
My question is very clear. On the day of surgery, BP is 150/100. Would you postpone or would you go ahead?
Sir, this answer cannot be given if on the day of surgery, if you are asking, you cannot do it. But it cannot be asked in such a manner if patient was a normotensive.
It has
you
happened.
Have seen.
It has happened, sir. Patient is normotensive pre-operatively on the... We are studying patients' BP through all positions of hair transplant, documenting more than 300 cases. For every position of hair transplant, the BP is checked. Every step, every half an hour we have checked BP recordings. That is a different thing. But Unger mentions a guideline, if diastolic is above 90, you should not be operating the patient. This is mentioned in the hair transplant book by Unger. But I am saying that in a practical aspect, how would you deal with it?
That's what I am answering. The situations, what you said can be in a way, one in which you presented. You don't know anything, patient comes and say, I'm never a hypertensive, my BP is 150/100, don't operate. But if I am taken a BP a day before, or if I have a real evidence that his BP yesterday or day before yesterday was the normal. In that case, I'll wait, give him midazolam, wait for some time, talk to him, then see, and most of the patient BP goes down to 130/90. In that situation, I'll operate. If a patient in which he gives history, that is, he is normotensive and his BP is 150/100, I give him midazolam, wait for some time, half an hour, 1 hour. If BP doesn't goes down, I don't operate.
Okay,
So
that
this
is very
the
clear.
situation.
Yeah. The only thing is that we should look out for labile hypertensives in this age group. It is this age group, because of poor lifestyle between 25 and 35, they will be normotensive sometime, and any kind of stress, even prone position, the moment you put them in prone, their BP goes up by at least 20. And I'm telling you, this is documented. So when you know that at the beginning of the surgery, the BP is like 90, you can expect it to go up much more when you start the harvesting. So that is something that we would want to, emphasize. Huh? Yeah.
Just wanted to add on this.
Yes, sir.
Yeah, the thing is, many times patients record the BP and send us the values. That is where one of the issues comes, because they might be in some other city and then you tell them that you do the recording. They may do self-recording, they may do electronic recording, or they may go to some place where the recording is not done accurately. And then they produce values which are incorrect, or you think that they are normal. And then if you are going to see them on the day of the surgery, it may spring a surprise for you. So this is one thing you must always ask whether it was done in a clinic, whether it was a mercury type of parameter or it was just
The home apparatus. I think, yeah. Okay, last question for that session that I am asking for the Dr. Venkat's thing about the attendant thing. It is, all of us face that problem because you have a patient coming from another geographic location and he comes alone. In spite of having mentioned in your email that you will need to get a person with you. Hospital protocols, Dr. Ram will say that they are very clear that you need a person if you are undergoing surgery.
yeah, it is there, but we have on request said that this has to be
Overlooked.
overlooked. So I've done it specifically because many, especially if it's under GA, yes, you are taking a risk because the signature is your signature as an attendant.
Okay. So even for local anesthesia, because of the duration of the surgery, see, for dental procedures you may not, you are giving local anesthesia, but it's a very small procedure. Here you have a 6 to 8 hour surgery, you need to be very careful. So having the contact number of next of kin with you before you start surgery is crucial. And I think that has to be put on paper that I am going into the surgery, I was asked to have an attendant, but as it's not possible, I am going ahead with the surgery and doctor has informed me of all the issues that can crop up because of this. So if you put that in the consent form, I think that is a fair thing.
See, that putting in the consent form, yes, definitely that is one step. But he has to give another telephone number. In one case, that damn telephone number was a wrong number. It didn't work. If that person could not be traced, even in that book, what I mentioned, Shirang Pandit, that's what he writes. They had that other person was sitting in the clinic for half an hour, fiddling with his mobile, and then disappeared. And when they tried to call, he was nowhere to be found, or the telephone number didn't ring. So that means this person, because you are insisting on a telephone number, he is giving it. Now, the question is not consent. Question is, if something happens, what would you do in that patient?
Yeah, that is a big issue. No, that is one thing we do confirm. We ask them to call them up.
The basic philosophy is that we should know, either he should have, or we should know his relative, or we should confirm that the number or the relation what he is giving is traceable in case of any problem. Many times the patients are, as Dr. Masood explained, that in that condition, and I think with clinical experience, many times you judge what this patient telling is false and lying, and in few of the cases I cancelled even the plastic surgery, even the very small surgeries like ear lobule repair tak I have cancelled. When I don't know patient, I don't know from where the patient has come, and even if I am doing the ear lobule surgery, I don't operate.
Okay.
Because I work in a small city where I know most of them. I must know, you must know the attendant whether he is here or not. That is the basic question.
One case, the patient got angry.
Mic is off.
Another number. Then we said we want to confirm, and he said, I have not told anybody at home that I am doing this surgery. Many of them are quite secretive. They don't want them to know. So then we took a
understand
friend's
that.
number.
That is quite common a scenario, but
Yeah.
I think on the day of surgery, it is important to know, let the patient know who's the boss, because it is not fair to go into the surgery feeling that you don't want to lose the surgery. I think that attitude will have to change. Okay, madam, the SMP thing I wanted to ask you. You mentioned, you showed the hairline video. Even if you are putting these dots at the hairline, I think even if you're putting single dots at the hairline, sometimes there is a possibility that they may become more obvious. So is it possible to stay maybe about 5 millimeters from the transitional area of the hairline and then take it?
I do when there are some hair are there. So I put the dots in the vicinity
Between the
of
hair.
vicinity of that hair.
Yeah, because that is
Not
important.
Not on the complete bald area.
No,
Because
no.
then it becomes so.
You don't augment the hairline
Yeah.
with that, you just stay behind the area. Now, you mentioned the depth about the thing. Now, the various instruments that are available have a device
calibration.
which you can calibrate. Now, if you actually calibrate it to 0.8 millimeters and you check it on a model, they are not very accurate. They are very
They are not
fallacious.
accurate.
And it also depends on the force that you exert when you put that thing. So the depth will actually increase.
No,
So-
depth is what happens when it is not operating. The depth is different. When it is operating, the needle comes out differently.
No.
So
The
in that you
pressure
can't
that you
calculate.
exert
Then
will-
you
will-
can't calculate the depth.
No, what I'm trying to emphasize is that
Huh.
you have to factor in the force with which you put the dot. Means your movement at your wrist that is
Yes.
going and putting. If you use excessive force, even if your calibration is pointed, you may exceed 1 millimeter.
No, you won't exceed that
Because
much.
at the skin, the epidermis can get compressed.
No, you have to just touch it on the skin surface.
That's what I'm saying.
If you're
That is it.
pressing it, yes,
Yes,
you
it
can
will
go down. But you don't press
Okay.
it.
One thing that I wanted to get clarity, which was not in the presentation, is the understanding of SMP pigments. Now, there is a big gray area on this. What kind of pigments are we talking about? We are talking of organic pigments, inorganic pigments, carbon-based pigments, metal-based pigments, because every pigment has a different implication where the outcome is concerned and certain restrictions on what you do and certain precautions that the patient has to take. So I would like to know what are the different pigments that are available locally and what would be the safe pigment that you would look at, attributes of a safe pigment.
I use a pigment from BioTouch because I have the color change is there in any.
No.
of the-
I'm
yeah.
talking purely on the content of the pigment.
Yeah. So I use from the BioTouch. It is an inorganic one.
That is the iron oxide one.
Iron oxide one. Versus your normal tattoo color. The problem with the normal tattoo color, there is a diffusion of pigment over time. Means if you put the dot, that dot will increase in size, the diffusion. That doesn't happen much in the BioTouch color.
No, the thing is that now there is an understanding that though we call these results as temporary, there is some part that goes off from the epidermis by virtue of the turnover of the
Yes,
cells.
correct.
And the one that is deposited in the upper dermis, a big amount of that is taken off by the macrophages.
Yeah,
But
so
the
the
pigment doesn't
insoluble
leave
part
the body.
remains. Yeah,
The
insoluble
pigment doesn't
parts.
leave the body. It is there in your lymph nodes. All the pigment stays in the body. Now, the important thing is specifically when you are using the BioTouch pigment, which contains iron oxide, it is important to emphasize that if the patient has to undergo an MRI, there can be artifacts.
It doesn't get detected in
No,
MRI.
it is, the point is that it is the quantum of the pigment on the scalp. It is, if you are going to diffusely give a tattoo, if you are going to create 50,000 dots, cumulative effect is going to be there. Artifacts are created, and I feel that these pigment particles can get stimulated with the force of MRI that is there, the kind of energy that is there. Some tenderness can occur in these patients if they are undergoing an MRI.
theoretical.
This is the consent form it is there on the consent form. That is why I am telling you. It is not the one that I actually looked at it differently, and then when I realized that this is something that I have to inform patients. If they choose not to have, because I don't have an option of payment. Carbon pigments are not available at the moment in India.
See, if you see that way,
if you go
the
to
whole
online,
body
Dr.
is being tattooed.
Rasman had
Then they will not go for
conducted
any kind of
2
the
or 3
MRI or
courses
CT scan.
on SMP in a couple of the ISHRS meetings. I happened to attend couple of them. And after that, I went through his literature, published literature.
No,
So the original one that was there, he talked about iron oxide. After that, he has switched to carbon pigments.
No, but then if you look at this tattooed industry, if you look at this all Western
can
people,
have a problem.
the whole chest and back is tattooed.
I understand.
Yeah, I don't know.
It can have a problem. They have the tattoo, but the problem can still be there. Okay. Just last question on this, because we are already running late. What would be your consent taking practice for SMP? How would you take? What would be the points that you would emphasize in consent taking?
It's a short leave. See, the
No,
scalp.
okay, let's split it up.
Yeah, I would take the consent that the results of SMP and the skull versus any tattoo on the body is totally different. In body, it remains for forever. I have got tattoo done for that purpose.
Why would that be?
I feel the circulation in the scalp skin is totally dynamic.
Both pigments are in the dermis only.
Yes, but
one
on the
is in the
scalp
upper
skin-
dermis, one is in the lower dermis. Quantum of pigment in the commercial tattoo is
No,
much
sir,
more.
no. I had done the same tattoo on my leg, and the same dots are still there since last 3 years. That's
No,
why I got it done. So same dots can remain on the skin forever for 3 years, and same dots can't remain on the scalp skin for 6 months.
No, it is not. It is the difference is in the depth as well as the
No,
quantum of
no,
pigment.
no, it's
Not
a-
the dots. I'm talking about the commercial tattoos.
At the same color. I use the same color on
If
my
you see the
leg.
process of commercial tattoo, the density that they get for the color, the pigment.
Same color, the same
No.
size of dot, same machine. I put it here, I put it on my leg. The dots are still here.
No, this is well known, Sandeep.
What?
While doing tattoo removal, there is a scale called Kirby Desai scale, which says that these tattoos on the leg are more
No,
difficult
I'm not talking about leg. Huh?
Other area, other than scalp.
The ones which are on the face and proximal parts of the body disappear faster because of lymphatics circulation as well as the blood supply. This is well known.
No, commercial tattoos may fade, but they don't disappear the way SMP disappears.
No, it's a commercial only. SMP is, if you take the same tattoo color, it is a commercial tattoo only.
They use the same pigment also, because BioTouch is meant for permanent makeup only. It is,
Yeah.
it's-
So
it's
I
more-
use the same commercial tattoo color on my leg and on the scalp also.
The only thing is that there is no FDA regulation for SMP pigments. FDA doesn't have a regulation on. And BioTouch is the company from US which has a standard content of the pigment mentioned on the bottles. And I felt that in the absence of any other regulation, to choose a pigment, it's better to look at this company which has been having permanent makeup pigments for almost a decade or more.
So what is the costing like, and how do you procure it, and where do you procure it from?
BioTouch is available online. You can go to Amazon. It will take about 5 weeks to delivery. They have the machine also, and the. Of course, there are dealers also, but if you are not from Bombay, you can directly procure it through Amazon, which will be marginally cheaper if you are willing to wait for about 5 weeks. No, but this is coming straight from BioTouch.
And do we need to
The BioTouch online also they supply.
do we need to mix the pigments or something?
No, I would not advise mixing, because then the color changes drastically. The brown pigment, if you use, leaves a orangish hue, and the black pigment leaves a greenish blue hue.
So you should only use black for
Yeah,
wherever
black,
we need
only black.
Okay.
Technically, there are different pigments that have been advised to get the right shade. Because our color is, the hair is black, it
Darkish
is okay.
brown.
But when you're doing it for someone with different colored hair,
Yeah. You
the
need to have the
pigment
specific
mixation
dye.
will be needed, but then those pigments are not available here.
No, but then we have done mixing of brown
Black
and
and
black, and the brown didn't stay.
The brown doesn't stay at all.
Doesn't stay at all.
Doesn't stay
In
at
1
all.
month, in fact, we have done the biopsy to prove that there was no
Brown
retention
doesn't
of
stay because
pigment.
it's probably the consistency of the pigment. You should not make it too liquidy. It should not become too thick also.
Okay.
The dispersion is less.
Fine.
Okay.
Thank you.
Thank you. Thank all the panelists and everybody. We are having a small open house. Now, this open house was basically for anybody to ask anything with regards to setting up the hair transplant practice, what are the staffing requirements, and anything that you would want to ask about hair restoration. आप रहेंगे? Dr. Rajput, you are back here. Yeah, please. It's pertaining to this? No, open up. Okay, I think Dr. Rajput will come. Yeah, please.
First of all, thank you very much for the lovely conference. We learned a lot through this.
Thank you.
And I want to ask the question that what are the things which should be mandatory in the discharge summary, and the concerns and the records to be kept for how long? There are two things which I wanted to ask.
I'll let them answer, then I'll answer that.
What are the mandatory things to be mentioned in the discharge summary of a hair transplant patient?
For the discharge summary to mention, as we have been doing during our post-graduation, you need to mention the details of the patient, the diagnosis, what he had, like endogenetic alopecia grade 5. Then the surgery done, the procedure, you can write in the procedure, hair transplant by FU or FUT, number of grafts were done this much. Then the surgical detail, when you mention it, then you write a short about the procedure. The procedure was done under local anesthesia, lidocaine, bupivacaine, or ropivacaine was used. For this much time surgery was done. During entire process, his vital parameters were settled. He had no unwanted reaction or unpleasant any reaction. Post-surgery, immediate post-op, you mention what is the condition of his vital parameters when he came out of the OT, and his vital parameter when he left. I also see to it, I mentioned when the patient went home from my office, he went up in his general condition, vital parameters were settled. Then we have made a protocol. So this was all we have mentioned in our, and the treatment also. Then the treatment for 5 days, then the long-term treatment, we give them the advices, what are the things he should do for the dressing and our follow-up, and everything we write on that. What things not to be done, what things to be done. Do and don'ts we also mention on our discharge slip. Then I have also developed a system of calling a patient from our office after 4 or 5 hours of the surgery. Like we finish surgery in 6 o'clock or 7 o'clock, then my office person, my assistant call at 9:30. When he call him, then he give me back. Sir, the patient is fine. Then we made it that another day, again 10 o'clock in the morning, means around after 18 hours or 16 hours of the surgery, again a second call goes from my home. These calls are noted down on my that original paper, admission paper. When patient comes on follow-up, we also mention it.
The thing that I just want to say, what he said is perfectly okay. It would be known as a treatment summary rather than a discharge summary because patient is not hospitalized. Two, when we share, you should have documentation about post-operative care as a separate cyclostyle sheet. Okay. Pre-operative care, post-operative care, and consent form which you can share. Now, the other thing that he mentioned is that you should emphasize about the number of hair, total number of hair that were got. 1 head, 2 head, 3 head, 4 head grafts, what were the bifurcation, and final total number of hair that were transplanted, apart from the total number of grafts you mentioned. I have this practice of giving tetanus to all patients who have not been immunized, document that on paper, the tetanus given, not given, and the patient is ambulatory. So patient left the clinic, means he walked out of the clinic. Calling up the patient is a good thing. Ask the patient to message you to say that he is fine. That becomes in itself a proof that he is okay. If you don't get the message within a stipulated period, you call him back. And the next day morning, your clinic calls him up anyway for a follow-up because we call the patient back after 48 hours for a wash. So that is how we monitor. If the patient is from out of station, then I mandate it that if it is best that they leave the place after 48 hours after the first wash. Any other question?
The next question was till how long you keep the medical records, the concerns? 3 years? Is it like
By
what?
Medical Council of India are supposed to keep for 5 years.
For 5 years.
5 years. You are
But you
supposed
can always, see, you can get a data entry operator Scan all of them and keep the soft copy on your server. Yeah, it's a better policy, because long term you can always have your own private small server in your clinic which can store the exhaustive data that you generate.
One more question I had about the holding media, and then the normal concern is like RL, ringal lactate is the thing, and PRP if possible.
See, the normal is isotonic saline or ringer lactate, any one of. Most commonly, word over is being used is this. Now, many persons are using hypothermosol with ATP, some are using PRP, like I use the PRP or plasma, platelet PPP or PRP you can use. What else?
The thing is that if you look at the results of hair transplant over the last 3 to 4 decades, majority of them are with using either saline or ringer lactate at room temperature or chilled. There is a lot of debate about whether you need to chill the saline. As a plastic surgeon, you will understand ischemia reperfusion injury. So that is one thing that you need to take into account. So just blanket chilling of the grafts also is not really proven. So there are a huge number of people who don't chill their saline. The other thing is that you can use any biological medium. So what we do is that we have blood soaked gauze pieces. We keep them in the same large dish. So you have that blood, automatically there are going to be those released growth factors, everything is there in that. So in that you dunk the grafts. Only when you have to count them, you put them onto the plain saline. So for a prolonged period of time, you don't have to do an extra procedure to get into the, generating the PRP or anything. But of course, PRP will be more efficient because you are documenting those many growth factors. But again, the studies that have compared PRP with any other solution are with very small sample size and huge variable factors. So one cannot conclude that one is superior to the other, but from a logical perspective, yes, putting in autologous substances with growth factors will obviously augment the survival of the grafts.
Now, I want to clarify on the point of chilling. This is a very common question, and you must clarify that. This is what is chilling, what is to be kept, room temperature, and what is the cool. Chilling means you are keeping graft at more than 4 degrees centigrade but less than 10 centimeters. That is called as the chilling. Cool temperature means 12 plus minus 2, around 14 degrees if you are keeping it. Room temperature means around 20-22. When not to chill is extremely important. If you are using a solution which is extracellular, means what are extracellular? Normal saline, ringer lactate, plasma, platelet, these are extracellular. If you chill them, there will be problem in the pump failure, and the more sodium will go in, potassium will come out, and the cell will swell up. So it is contraindicated to chill a solution or a graft which is kept in extracellular. It's very important, it's written, and you must read this article. They should be kept at the cool temperature, like 10 degree around. Another thing, if you chill a graft, there will be reperfusion injury will be more. Why? What is reperfusion injury? When the temperature of the graft at which it was stored and the body temperature, if the difference between the two temperature is vast, there will be, that is called as reperfusion injury. Now I come on, when to chill. When to chill? If you are using intracellular, what are the intracellular holding solution? Like hypothermosols. These are, and tissue culture media, basically. These are the intracellular fluids which requires the chilling. Chilling doesn't mean freezing. Okay, I explained more than 4 degree, less than 10 degree is called as the chilling. So it's a very clear cut line. As far as the platelet-rich plasma is concerned, Dr. Satur said is right. But there are many papers and research on platelet-rich fibrin scaffold in which the entire tissue, like the conchal cartilage, has been cultured. This is being used to transfer the cultured cell. This has been used to culture the cell. And there are enough papers. In my article, I have mentioned all the papers in which detailed research study has been done on use of platelet-rich 3D fibrin scaffold and the utility to improve the survival of the cell.
Thank you, sir. Thank you. Thank you.
The first question, among two, saline and RL, which one do you choose?
Saline is only isotonic. So ringa lactate, if you choose, is more physiological. Saline concerns only with sodium concentration. Ringa lactate would be a little better in electrolytes as compared to saline, means only between the two. Otherwise, platelet poor plasma that you create or PRP if you want is better than ringa lactate.
But again, there is no published data which says sodium chloride is better or ringa lactate is better. It is just from a rationale that is more physiological. Ringa lactate would sound to be better, but if you look at the results published through the last 4 decades, everybody has achieved the outcome that they want using. But now the difference is coming because of our grafts being more fragile because of FUE. Strip grafts are robust. They will survive the transfer much better than FUE. That is why this whole debate on holding solutions. If you are doing FUE, your grafts are really, really fragile. So whether it is staying out of the body, whether it is handling them, whether it is implanting them, everything has that extra bit of care that you need to make sure that they survive.
Another very important thing for graft solution, as Dr. Satur mentioned, whatever solution you use, graft out body time is very important. If graft out body time is less than 2 hours, the study shows it doesn't make any difference. If graft out body time is more, then there is an importance of graft holding solution.
Yes, sir. Coming to the concept of cool, can we keep it in the refrigerator? In a
No,
normal
don't keep them in refrigerator.
It will go much lower than that.
Much lower. Temperature. Okay. No, never do that. Okay. One of my reimplant failed because I gave them to keep it in the cool and they kept it in the freezer. And when I implanted, every time I was anastomosing the vessel and used to block. When I saw that because of the crystallization, the cell burst out.
Not the freezer, sir, the vegetable compartment.
No,
not
it is
that
still not advisable.
No, not sir. There is no temperature.
Third question, sir, regarding management of the bleeding. So nowadays what I am seeing, even everything is normal. Bleeding time, clotting time, if BP, pulse, everything is normal. Patient is on the table, and suddenly even if INR is more than 1, even if it is 1.1, there is a lot of bleeding. So I am giving prophylactically 2 pause tablets, 2 tranexamic acid.
What tablets?
Tranexamic acid.
Why?
500. So is it justifiable?
No, in my opinion, not at all.
Try and locate the reason for bleeding. One of the reasons for, all this come to you with experience. As a surgeon, if you were to realize, one of the commonest reasons is that patient is going to be on that table for maybe 6 hours. If you have not given him a washroom break, his bladder is full. He has definitely, his systolic has gone up by 20 millimeters. That itself could be responsive. Once the systolic goes up by 20 millimeters, the capillaries in the intradermal and subdermal plexus are going to be more profused with blood. So that oozing is going to be there. So check the BP to see what is the cause of that. Don't think that there is a bleeding disorder. It could be something more physiological that has caused the bleeding.
Yes, sir.
And pain. Pain is another thing. Patients may not complain, but even some kind of pain can raise up the pressures.
But before the surgery, sir, I give him washroom break, then check his BP, pulse, everything.
Still the bleeding is
I give the anesthesia. After that, I check the BP. Then once, I use only 0.9 mm only, not 0.9. So just when a bleeding starts, I am giving whenever the bleeding is, I will give 1 tranexamic acid 500 mg injection.
But you think it will work that soon?
Injection. But I am able to do peacefully.
I
You
have my
even
doubts on that.
check the flexion of the neck. If you have propped up the neck and if the neck is flexed, venous drainage is getting compromised, the scalp gets congested, and within a while you will find excessive ooze. So if you're flexing the neck too much and if the position is not right, it does lead to excessive oozing. Your patients, if they are smokers, very, very commonly if your patients are teetotalers, okay, we have a cardiologist, 4 o'clock in his clinic every day he has his tea. On the day of the surgery at 4:20 his bleeding starts. He is oozing like mad. I don't know what to do. We hold, we wait, we did this, we did that. Wife is coming in, peeping through the glass what's happening. So we are holding. Wife is a doctor. Okay. She is MBBS. She practices with her husband. So she knocked on the glass. So I went there. She says, can you give him a break? So yeah, we can give a break. So she said, can you make some fresh tea? Well, yes, we'll make. Well, it is his tea time. If he doesn't have tea at that time, he goes mad. So we gave him a break. Fellow had a sip of tea, came back absolutely comfortable. So this can be very silly things which we can't seem to be right. I had a patient from Korea. He was oozing. I kept on asking, any discomfort you have, any pain you have, anything I can do, something is raising your BP or something is making you uncomfortable, we are having oozing. Even our implanted grafts are being pushed out. So he said, can I have a smoke? So fellow changed clothes, went outside in the lobby, had a smoke, came back, and the oozing stopped. So every 2.5 to 3 hours, you have to give them a washroom break to relieve the bladder. Ask them they want to have water, tea, coffee, something. Just keep them comfortable. Slightest anxiety or slightest discomfort, flexion of the neck, bolsters for positioning. You're lying down on a flat chair. Sometimes the shoulder is paining, sometimes the back is paining, sometimes the knee is not right. Okay, so we have got 6, 7, 8 silicone pillows and bolsters. Anything patient says, you try to adjust that. We even have a car seat massager. When the patient sleeps on the table during implantation, it's not a great massage, but little bit of vibration is going on in the back and the patient just dozes off. And you have got no problem. So this always may not be a systemic problem or always may not be related to an health issue. It could be peripheral issues that you want to sort out.
On a habitual tea or coffee drinker, tea or coffee allowed on the surgery day, sir?
Yeah.
See,
Our
technically,
patients are not
it's
NBM.
advisable to avoid it before surgery. Because it does increase the bleeding thing, but the quantum of coffee and tea that you drink is not that high compared to the West, where they drink just pure black coffee with huge mugs. Our portion sizes are very small. So we don't deny the patient on the day of surgery.
Yeah, and in Bombay terms, it's a cutting chai. Cutting chai is half glass.
Should we prophylactically give vitamin K injection even if the INR is normal or not? And if we give, what are the side effects?
This is a practice that is there with many surgeons. Prophylactically for 3 days they will give vitamin K. There is no documentation of whether it helps or doesn't help. And I feel that doing anything that doesn't have enough evidence, we see there may be no side effects as such because it's only a vitamin that you're injecting. But at the end of the day, if you are able to rationalize whatever you do, there has to be a rational basis to what. If you're trying to prevent something, you'll have to document that there is a problem and I'm trying to prevent that. But just giving vitamin K randomly, I don't see any benefits of that. But it is a hugely popular trend amongst a lot of specialties. It is not only with hair transplant, but it is there with a lot of specialties. It is by default a pre-operative instruction written in hospitals also.
Usually I ask the patient to have 3 injections, maybe 5 to 7 days before the date of surgery.
But then that effect may not last till the surgery. It's generally given just 4 days or 3 days preceding the surgery. But anyway, that is, I don't see any evidence, but I don't know what...
No, my philosophy in hair transplant is minimum medication. That's I don't know which drug is going to react with what. So, as a blind, I become blind. नहीं देने का, फालतू चीज नहीं देने का. I don't know which drug will react with what. So this is a minimum medication, minimum combination, minimum formulation. That's what I adopt in hair restoration. But vitamin K, rightly said Dr. Sattur, it can be given, but I have never given.
Sir, if we use minoxidil 1.5 months before surgery to improve the donor area, does it increase the risk of bleeding during surgery?
You have to discontinue it about 10 days before the surgery. What happens is that when minoxidil has its benefits, there is a definite increase in the subdermal capillary blood circulation. There is no dispute on that, that the blood circulation in that area has increased. So perifollicular blood circulation, when it increases, is going to cause a little more ooze. But even sometimes by accident, some patients forget to discontinue and we don't see much bleeding. So it is not mandatory that you will see bleeding, but on a prophylactic note, stopping it 10 days before the surgery is a good thing, and starting it after all the scabs have fallen out is another practice that people have, because you keep it withdrawn for a long time, again the patient will have more effluvium. So you put it back as soon as the scabs have fallen out, because that skin that has healed is like baby skin, it's tender skin. So don't start with 5% or 10% immediately, because the concentration of alcohol increases with the strength of minoxidil. So it's best to stick to 2% in the first maybe 4 weeks and then step it up to 5%.
Can we start it 48 hours after surgery?
No, I would not recommend it, because though technically the seal, watertight seal between the graft and the recipient area has occurred in 48 hours, it is not a guaranteed thing. If the minoxidil were to get directly absorbed, apart from the systemic effect, it can also have a local damaging thing, and there is no benefit of putting minoxidil in the recipient area 48 hours after surgery. Why are you
inviting trouble? It will cause irritation also.
See, a surgeon will never interfere with the post-surgical wound so soon with another medication or a chemical.
Sir, thank you, sir.
Sir, my question is, sir, what is the consensus now, like on the dais also? Most people use minoxidil after surgery, probably either in the conference, probably I missed a day, so I could not get this information that using minoxidil after surgeries, what FUT surgeons are following, what FUE surgeons, because in most patients when minoxidil is stopped, the density drops down. That is my experience, but probably I would like to know your experiences also.
The thing is that what I said in the presentation today, I don't know if you were there today when I spoke about it, it is very clear that hair loss is going to progress. Your transplanted hair may remain for a longer duration, but the existing hair is going to get weak with time.
Sir, in completely bald people.
In completely bald people, it may not have relevance. If you are looking at an area that is completely bald, then it may not. But if you are having miniaturized hair present in the fringe area, where if you have implanted in this area and surrounding that entire area, there is a fringe of miniaturized hair, there is no harm in giving it. But once you start minoxidil, I would say it is for life.
Your question is post-hair transplant.
Post-hair transplant.
In relation with the success of the hair transplant in relation with the transplant.
Yes.
The answer is, it is clearly written in the books, in the Angar also, and there are the studies also. There is a very common study in which the after transplant minoxidil was given. The advantage of giving the post-transplant is reduction is effluvium, early hair growth, and increase in the number of hair growth. The studies are there in the Angar, you can read. So in all my patients, all transplanted patients are on medical therapy after hair transplant and also before hair transplant.
Sir, but most patients, they stop it after 1.5 to 2 years because it's tough to continue.
Okay, it's fine. Okay, it's fine. They can stop after 2 months. But if you are giving post-hair transplant, the advantage of immediate use of minoxidil after transplant is reduction in the effluvium and early growth. That's the advantage in relation to the transplanted hair. They can stop it afterwards. If they are in already grade 7, they don't need it. They don't need it.
Sir, another question about the slits like coronal versus sagittal. That many people discuss that coronal gives better density versus sagittal, but sagittal we can place more number of grafts because of the closeness. And what gives better and natural results in your experience? And sir, Dr. Satur, what do you use? Coronal versus sagittal?
It depends on I use a hypodermic needle. I still do stick and place. So it's not technically a coronal or sagittal, because the hypodermic syringe creates a U-shaped kind of a...
So sir, it's vertical or it's like this?
No, I take it as in that way it is more coronal. More coronal. Okay. But if there is existing hair, pre-existing hair, I am working within that, then sagittal would be a better option to prevent damage to the existing hair. But if I am looking at achieving a better, illusion of density, then coronal is better.
Okay, thank you.
So my question is, like when we do hair transplantation, we come to know the final result after 4 months, 5 months, or maybe later.
Final result?
Yeah, the results that we're going to get maybe in few months.
Starts at 4 to 5 months.
Yeah. Why I was thinking, like when we put a graft, it's a graft, and by 1 week it starts getting blood supply, first from osmosis, then the blood supply starts forming. So by 3rd week or 4th week, before the shedding has started, can't we make an assessment how many grafts would be coming in the final result, or no, we can't make on that?
I don't think so.
No. We don't think so. We can make an assumption this hair will grow or not grow. I don't think so. We can make an assumption. If you want the early to see, the best shortened way is just you can use a minoxidil. That will make a difference of hardly a month or so. Otherwise, really you cannot predict. And the final assessment, also you write in your discharge slip and explain the final assessment of hair transplant cannot be done a year before. At 4 months, you will see, yes, some hair has started coming. At 5 months, patient become further unsatisfied because few hairs are initially thin, they are sparse. So always make it a point that the final assessment will be done a year, cannot be done a year before, and I can only give you final verdict how a transplant is after 1 year. It is always safe and explained many times.
Hello, sir. There are many patients who are NRIs, come from out of India, and while going out of India, we give them finasteride or multivitamins and all. So many times they told us that we'll take it in stock from India to wherever in America or Dubai. So how many months stock we can give to them, or can they carry? I give them prescription and all, a stamp and all, but still how much stock is allowed to take out of India?
There is a different, the regulation varies from country to country. Okay. In the US, they will clearly check the duration mentioned on your prescription. If it says for 2 years, they will admit it. They have to know that the medicine that you're taking into the country is not for commercial sale. That is their concern. In Canada, they don't permit more than 3 months. So even if you give a prescription for 12 months, they will take off the rest of the things and throw it in the dustbin. They will not use it. So every country has different regulations, and you need to check with the patient about, with each country it is different. But generally US, UK and most of the Middle East there's an issue about alcohol. So that, most of your minoxidil will contain alcohol. So there could be a restriction on that part. But where the amount of medicine you can take, I have had patients who have taken 48 bottles of minoxidil to UK with no problem. And in Canada, it is very particular. That the problem is that finasteride is a prescription product in the United States or any other country in the world. So if they have to procure finasteride there, they either go to their GP and get the 5 milligram finasteride and make it into 4 parts, which is cheaper, or go to a dermatologist with a $150 consultation and buy another $150 worth of finasteride for 2 months.
Thank you.
Can the patient fly within first 48 hours after that transplant?
Patients are flown on the same day after a strip surgery, after an FUE. But on the treatment summary, it is important to mention patient is fit to fly. If that is not there, they can offload the patient. It has happened to a patient of mine because that one line was not there. But technically, from a surgical perspective, there is no issue because of the pressures or whatever you say. There has been no issue. But ideal situation would be to fly after 48 hours. So I tell all patients that don't fly on the same day. So that is thing. I don't know what Dr. Garg and Dr. Rajesh will say.
Yeah. Intercity they can fly. Means from Delhi to Mumbai, they can fly even on the same day.
No, unka kehna hai ki
that's what I am explaining. Intercity they can fly, but overseas it is better after 48 hours.
नहीं सर, एक बार आप flight में ऊपर गए,
remain the same.
Height उतना ही होगा ना, 35,000 feet पे जाएगा.
Longer time. Longer time.
Yeah.
1 घंटे का mostly 1 hour flight is there. It's not going to make difference.
I get your point.
But if he is going to USA, 24-hour flight is there, then it's better you tell them to 2 days rest and then they can fly. And otherwise also we tell patient is from outside, it's better to stay 1 night in the hotel and then in the morning you go. It's better. और रिटर्न में तो देने का ही नहीं, you can fly.
Yes, Dr. Joshi.
One question I wanted to ask, is there any protocol for evaluation of failed cases? This is pertaining to just one case that I want to say here. One patient of mine, very good, well-educated, nice family. I did a full strip, 2000 plus grafts. After 1 year, no growth. This was just 3 years back. I was surprised, I didn't know what to do. I told him, I don't know what went wrong, but I did a second session, I tried FUE. I did only 500 grafts of FUE, just thinking that what will happen, whether it would work or fail. Even after 1 year, 500 FUE grafts have failed, no growth. I'm still surprised, I don't know what to do. What should we do in such cases? How do we proceed?
So
Only one case in last 15 years, I've never found it in anybody else.
This has happened with me also. One case of FUE lost the total hair. What was initial, so there are many causes apart from technique, what you know, I don't have to explain to you all these causes. I think there is some inherent systemic disease which we could not diagnose at the time of implantation, apart from all aspects.
I got even that evaluated from a physician. Patient is perfectly healthy, 27-year-old. Nothing wrong. We don't know what is the problem.
No, the thing is that what he's trying to say is that he has been performing this surgery for last 15 years. His protocols have not changed. The way of doing surgery is the same. Then why one patient stands out without any growth?
It's the overlapping pathologies in hair loss. Hair loss, which a couple of years back, say you can just say 18-20 years back, was purely androgenetic. Today, because of the rising effect of pollution, because of the toxins being laced in your food, without your consent, what you're eating is containing toxins from insecticides, pesticides, fertilizers, preservatives, processed foods, so many things. So the overlap between cicatricial alopecias and androgenetic alopecia is increasing. That is what I presented, that you are having cicatricial pattern in androgenetic hair loss. You got cicatricial pattern hair loss.
Even my dermatologist has evaluated him. Normal scalp.
Dermatologist, not all are.
I sent him to my dermatologist specifically for evaluation.
Not all have their eyes open
scalp?
to suspect that there could be an angle of cicatricial hair loss to this. And these frontal fibrosing alopecia, fibrosing alopecia in pattern distribution, they get aggravated after doing your hair transplant. So there are cases where they would be having underlying frontal fibrosing alopecia or cicatricial alopecia pattern or alopecia incognita, and they get aggravated after your transplant, and you ultimately find your transplant is not resulting into anything, or the patient says growth is coming, he sends you a picture at 5 months or 7 months that this growth is coming, I hope it is better, and 10 to 12 months later he sends you a picture where there is nothing, it's gone. Also, we have had follicles that begin to grow. They grow for like 4 or 5 millimeters and stop. Now your graft is there, it is taken, growth is started, but it's not continuing the growth. I've tried various aspects to find out an explanation for this, apart from the unknown or undetected overlap between cicatricial pathology and androgenetic hair loss. I can't find any other explanation.
I'll just emphasize what
next
Rajesh
question
was
that
saying.
I
I'll just complete to the Raj. Two things are there. One is the use of trichoscopy has increased in the last 10 years, which was not there 10 years earlier. So it was very easy to miss these cases which were already there. See, these things are coexisting. They have been there from the beginning. It is just that our awareness and our assessment has improved now, that we can on trichoscopy pick up things. You will not believe the number of scalp biopsies that I ask the patients to go through just because I find something suspicious. So I will ask Dr. Khopkar, you have a look and you get the biopsy clarified, what it is it am I dealing with. It has happened innumerable times, and many a times he has said that it could be this or that, I cannot comment on the biopsy also. So there are times when, like Rajesh said, there could be an element of cicatricial alopecia which could, these have been presented also, that frontal fibrosing alopecia is very common, and especially in the frontal area, the hair loss can happen either after the full result is there or the result may not even come up. And that is the reason, if the second time the same thing has happened, then there is an underlying pathology in the recipient area. So probably a scalp biopsy would reveal, but once you have already performed 2 transplants, scarring would have ensured that, you will not get a virgin tissue to diagnose what, the problem is. So scalp biopsy after hair transplant, I don't know, Dr. Dhurat, whether it is going to have a clear picture for us. No, but even after doing the incision, some amount of fibrosis will be there.
In that case, you need to see in the biopsy whether the fibrosis is throughout the dermis or it is just localized.
Specifically.
Specific fibrosis.
Okay. So that is the only thing that I can think of, and what Rajesh said is, it could be an underlying pathology which could have been missed. It is possible with anybody. It is not that one person has missed it. It has happened to all of us because we are...
No, but even after later evaluation, there is no pathology.
With a biopsy also?
Yes.
No pathology?
No pathology.
Then it is a little
That
difficult.
is why I am perplexed. I mean, and next question is what to do further. Now I have no advice for him. He keeps on asking me, doctor, what am I supposed to do now?
I would suggest that to cover the bald area, hairpiece would be the only way to go
That's
forward.
what I told him.
That is the only way to go.
We cannot do any further experimentation in such cases. Yeah.
But it is, I think, if you have all the data from this case, it is worthy of presentation, because that is the only way the specialty will progress.
Yeah.
When people know what you have, see, I will not have in one lifetime is not enough to learn everything about one specific thing. So if the more you present, the more, in fact,
Yeah, I'll present this. I have the entire data on this case.
Yeah, because that is important. Yeah. And I think you should have the dermatologist present so that they can give you some opinion on this.
Yeah, I will. Sure, I'll do that. Thank you.
I think
to add to the same discussion, I had one patient in the half side of a particular patch did not grow. The same technique, same protocols, everything is the same. I have some good amount of experience with the cases now, but one particular patient, maybe that's the implanter, because the staffs keep changing sometimes. I don't know what went wrong. But on a redo, it grew back.
So that means that the implant, see, in his case, he does the implantation. I know that. So if the same person is doing the same thing over and over again, then that is relevant of, some underlying pathology. Anything else?
Yeah, there are some instances of asymmetrical growth. But if you analyze these patients, their hair loss also initially is asymmetrical. There is a difference between the blood flow in the right half and left half of the scalp. You will get patients who have got receding more on one side and less on the other side. Or you have got patients who are showing miniaturization extensively on one side, significantly better than the other side. Just without trichoscopy, just by looking at the scalp, you can recognize that there is a variation. These patients, we tell them pre-op, you're going to transplant, but see, this side your growth is going to be slow or less. This is slow to begin with. You are having more of the pathology here, whereas you just keep a picture, a hand on that picture on right side and left side, the other side looks better. And you keep here, this one looks worse. So we convince them that this is the pattern you are having, there's an asymmetry. And this indicates that I do a transplant, your growth is going to be asymmetrical. You are going to need one more sitting on this side. Now, after having said that, patients tell me, in my childhood, I had a tumor, I have undergone radiation on this side. Okay. Second fellow, he tells me that, yes, I had a athrobatus lesion or something in one of the carotids, which is treated, which now is not there. So such things can happen. They could be also idiopathic. Out of many patients, these are the only two where I got a reason why this was happening. This can happen even without any reason. Maybe just by the biology of the body, two things are not symmetrical on the scalp, and you could have difference in response on the scalp on one half or the other.
I just wanted to ask this question to you and Dr. Ramchandran also. Sir, have you come across patients with hair loss post-radiation therapy? And if these patients have a pattern distribution, but everything looks weaker, would you consider ever a surgical intervention in these patients? No, there was a patient of leukemia who had undergone radiation. It was a whole body radiation they had given, but he had an impact on the scalp also. And if it is specifically related to the brain, then I don't think we should attempt to do anything, because that will get worse with time. But if it's a whole body radiation, then what is the approach that we should have?
I can't answer that because I have not dealt with it. But one case which I remember was a child who was just about 8 years old, 12 years when I saw him, and 8 years has undergone a DMT.
Okay.
So probably one of the xenophobic and lost very significant. And they tried almost everything in terms of medical treatment, and they referred for a possible surgical consult, which was just for completion. And at that time, I actually suggested this to be put on the therapy with radiation advocates. And I almost forgot about it. But after a year, they came back with a significant amount of improvement in the hair growth for this child who had undergone chemotherapy and DMT with alopecia and 4 years duration. It's not that it's a recent thing, and routine medicines had already been tried. So maybe it has to be looked into. I'm not very sure whether radiation also has to be.
Because as plastic surgery, we face these tissue deficits post-radiation. The radiation injuries get worse with time because of the end arthritis that is caused by the radiation. So, given that scenario, I was wondering whether the vascularity of the scalp also will be, impinged upon if you have to do anything surgical, sir.
I had operated one case of hair transplant post-radiation around 6 years back. Originally, the patient had some sarcoma over the one of the parietal region, and trapezius flap was done by me only. Patient came after around 6 years, and patient had was able to cover if he grew longer hair, but came to me for coverage of the area. I said I'll be able to cover the area reasonably in maybe 3 or 4 sessions. And I had done hair transplant over the irradiated trapezius flap, myocutaneous flap. And the density was around 12 or 13. To my surprise, all of them grew.
Okay. That too when the radiation was given specifically to that area.
That area. And it is myocutaneous flap from the back.
That is one of the reasons why it probably did well, because there is a robust blood supply coming to the skin from the muscle, which otherwise in the scalp would not have been there.
Yeah, the radiation patient example that I was speaking just before is surgeon Dr. Kerkar, cancer surgeon in Tata. He's undergone hemimandibulectomy and radiation for some blastoma in the mandible at that time. And I did his transplant is growing well. Now another advantage I have is if I have this doubt whether the two areas are having good blood flow or whether it will respond or not, I play my trick, I put them on the medical therapy. And if you see that there is some response in the hair, and this is trying to grow better, it means the vascularitis and all that shouldn't be suspected. You can do a transplant, tell the patient we are doing a trial density, not fully packed, we'll do this in 2-3 sittings, and you can see the result and then proceed. But that allows you to just do a test whether this patient is going to respond or not. So for that, we also had a patient who was negative on the test. I had a patient who has undergone chemotherapy, radiation, everything some 18 years back, but like nearly totally bald. Just a few hair growing here and there. She was wearing a hairpiece. So anyway, covering the entire head was out of question because you never had any source for doing that. She's already wearing a hairpiece, is already adjusted in life. But to this patient, I gave the medical therapy just like that. She said, "No, but give me at least something. I came, you have to do something for me." And she did not respond to it. So maybe the dose of the radiation is different, or maybe even after so many years, the follicles were not surviving because any which way, the extent of baldness that she came with was too much. So that was just to share a case.
Yeah.
I've had a gynecologist with a brain tumor excised almost 10 years back with a temporoparietal full area hair loss. The scalp was normal, no hair growth. Normal in the sense the scalp was little atrophic. She requested for a transplant. I did 200 grafts as a test grafting. Grew very well, and then I have done a full session of more than 2,000
So
grafts.
there was no
with
problem.
Good result, no problem.
But I think doing the test is the key
grafting
here.
is important.
Is
yes,
the key.
It's key. It's a key. Yeah.
Any other questions? So should I conclude the session? Okay. So thank you all for being here at the end of the day of the conference. Thank you very much for the patient hearing. Thank you. The people
Thank
who
you,
have
my dear. You are still here for that. Usually, most of the candidates run away after 12. But
thank you. And I hope everybody has had the, those who are staying here have checked out of the, okay, thank you.
Yeah. We thank the panelists and Dr. Satur for an excellent discussion.